Hello, everyone. Welcome to today's Pharm lecture. Thank you for your patience and flexibility with all this shelter in place. Hopefully everybody's at home unless it's absolutely necessary to go out. Today's lecture that we had earlier on Zoom unfortunately didn't go that well. We tried it through Canvas and that didn't work very well. Through ConferZoom. It was oversaturated when I called into the IT help desk. God, there was 40, 50 people. I called a couple of times and a very long waiting list. So we tried outside of Zoom, and that also had very poor connection. My assumption is the systems, both of them, all of them, are being oversaturated with people in colleges throughout the nation, throughout the state, throughout the Bay Area, using the same systems. So let's try this. I'll upload it and hopefully it works well. And I am going to go slightly faster through the first 21, 22 slides out of 42 because we covered already half of this material online until we just got tired of being disconnected. So again, thank you all for your patience. Let's jump right on into it. You can see here that this is just a brief and quick review that shows what the skin is composed of. It is the largest organ of the body as far as we're aware of. There are two layers, dermis and epidermis. A lot of the topical transdermal medications we give will be in one way or another affecting either of these layers, mostly the outside layer. The functions of the skin are multiple. We know that it serves as a barrier and that it can sense changes in temperature, pressure, pain, regulates the body temperature, helps to excrete fluid, electrolytes. If you sweat a lot with sodium, for example, helps store fat. And it also is a site where vitamin D is synthesized, so not everybody can or needs to be taking oral vitamins. But that said, if you tend to have, or your patients tend to have a low vitamin D3 level, then sometimes they can synthesize it in the skin more or less, or absorb it more or less through the GI tract. Sometimes they need to be getting sun externally through the skin, but also taking a supplement in order to boost up vitamin D3. And we know that it's important for many things, such as building the immune system. And we know that the skin is also a site for where drug absorption happens, and we give those through a bunch of different ways: transdermal, topicals, patches, ointments, creams, gels, and so on and so forth, which we'll cover here in this lecture. We'll cover this microscopic view of the skin as we go through specific medications. Remember, we're in the Pharm RN28 class, not med-surg. So in terms of dermatological drugs that we use topically, there's basically quite a few different antimicrobial, being bacterial, fungal, antiviral. There's also quite a few steroids, corticosteroids, different types of medications we can give as well that are anti-inflammatory. For certain types of skin conditions, we give anti-neoplastic drugs, antipruritic. Pruritic just means for itching, and some burn drugs. I also would say that for dermatological issues, we will be seeing quite a bit more, at least in the acute care or critical care setting, wound problems, pressure ulcers, surgical incision sites where drains, JP. Also, if a patient has an external fixator on from an orthopedic surgery instead of internal fixation, they do an external. Those are sites that will have to be monitoring for infection as well. And the further dermatologic drugs that we have, the emollients, some people use them for moisturizers. They work mostly on softening the skin. Keratolytics, there's quite a few different words for that, but basically the stratum corneum or the outer layer of the skin sometimes is affected by a lot of the medications that we give, in many cases intentionally. For example, some of the peroxides we give are cytotoxic, and that's intentional. Of course, we would have to know and expect that some of the side effects would be peeling of the skin, warmness or sensation of warmness to that topical or local region, and peeling of the skin as well. Sometimes even discoloration of the skin can be an issue. There are a lot of local anesthetics that we can give as opposed to generalized, a lot of times lidocaine patches of such nature. As we covered today when we tried doing this lecture through Zoom, we spoke about topic vasodilators, and I asked you guys to give me an example of one vasodilator that is quite commonly used in the hospital, and a few of you came up with nitroglycerin, which was great. We can give those sublingual, that's very common, but sometimes you'll see the nitroglycerin is given through sort of like a white ointment gel-like substance. You have to have a paper that goes with it. So when you pull it out of the Pyxis, pull it out of the machine, or call the pharmacy or go pick it up, make sure you have a pad of those papers. You only need one sheet, and on that sheet it'll indicate 0 to 0.5 inches, 0 to 1 inches, 0 to 1.5, or 0 to 2 inches. And the order in the MAR will specify how many inches we need. We just put a line of cream from 0 to 1 inch, if that's what the order is, and we take it, we face the cream or the gel towards the patient, and we put a tape on it. And then of course we want to identify what medication it is, if it's 1 inch, 2 inches, 0.5 inch, what time you put it on, and your initials. There are quite a few debriding drugs, we'll go over that as well, and then sunscreens. And I made a point about sunscreens. They're extremely important in people and patients, especially who have family history or personal history of skin cancer, and yet sunscreens can block vitamin D3. So if the person is having issues with vitamin D3, then using sunscreens in most important, like when the sun is higher, maybe around 1, 2, 3 p.m., is okay to use it on the face. But we want to try to not completely in other words, we need to educate our patients that sun is important, that we do need to get the vitamin D3, even if it means getting some of it through the legs, through the arms, through the chest, maybe covering your face. So it's a balance between the need of D3 and the need for sunscreen, and it's really case by case depending on the personal situation, family, or personal history of cancer, skin cancer. We already talked about the different antimicrobials that we're going to cover now one by one, basically attacking bacteria, attacking fungal or viruses. The most common bacteria that we see or we will be seeing are Streptococcus pyogenes or Staphylococcus, so strep or staph. And these are a lot of the problems that we'll be seeing. A lot of times outpatient, sometimes cellulitis you'll see a lot more in acute care, because cellulitis can be dangerous and they may be hospitalized if they need IV antibiotics. Some of these others are more outpatient chronic care settings, but you may see them as well in the hospital. Nonetheless, we still need to know what the medications are, which generally speaking for bacteria are bacitracin, neomycin, polymyxin, neomycin, and combinations. Combinations tend to work really well, Neosporin. Bactroban earlier today when we were on Zoom was the example where I asked you if anybody had seen it, if we have used it before, what route. We tend to give it through the nostrils. Remember, MRSA is something that is an infection that is basically methicillin resistant. That's what the MR for MRSA stands for. And so a lot of people are becoming resistant not only to IV antibiotics, but even to Bactroban as well. And remember, patients can have MRSA in a wound, which generally is a systemic, thus the treatment for the most part tends to be systemic, IV antibiotics. But when we test all patients coming into the hospital, if they're positive, not necessarily in a wound or an incision, but they're positive in the nares, we need to treat them with Bactroban for about 5 days in acute care setting. And we may keep them on that contact isolation for the rest of the stay in the hospital, but that doesn't mean that they're as infected, especially if they've been treated with Bactroban before. It's again topically used for things like impetigo as well, but again, the most important thing for acute care is to know that we use it intranasally for MRSA as well. It is a prescription, doctor ordered. We spoke at length regarding sulfadiazine and how it's a topical anti-infective. I did mention how in naturopathic settings, you can go to Whole Foods or Nugget, and you could, and over the counter, they're now selling even certain types of silver sprays to take internally, orally, sublingually to boost the immune system and fight some of the infections that they have internally. It's not that much seen in acute care or critical care setting. You will see it tremendously present in hospital situations in wound care and on certain specific types of dressings. It will require an order from your doctor to be able to put a dressing that contains silvadine or silver in it. Do make sure that you inform your patients that it can cause pain, burning, and itching. That's normal. What you want to also always ask is if they're allergic to silver or sulfonamide drugs, and pay attention to the sulf of the sulfonamide and the sulf of silver sulfadiazine, because that's where the allergy is happening to, sometimes even allergies to sulfur. I personally am slightly sensitive to silver. If I put silver chains around my neck for the first 24, 48 hours, it will not affect me. But after about 3 days, I'll start to see little red areas on my neck. I have to take the silver off. So I've never had to use sulfadiazine at any point for wound care. So I don't know if I would have an allergic reaction, but these are all things to keep in mind and ask our patients. Remember, we always want to think patient safety first. Acne is caused by this specific propionate bacterium. Also, it happens more in certain specific populations that are going through hormonal changes. So treatments will vary depending on the level of chronicity or the level of acuity. But we do use quite a few things to treat acne, as you can see on this list. Isotretinoin is the main one that you have to be pretty careful with because it has some pretty bad side effects, such as depression or suicidal ideation. You have to monitor the liver. And so on and so forth. A lot of the tetracyclines and the retinoids, you have to be careful for their teratogenicity. And I had asked you guys earlier today if you knew what that means. And it just means that if someone is pregnant, that it can cause damages, defect to the baby. And obviously you don't want that to happen. So be aware of that. We do use the drugs not only to treat acne, but to prevent acne as well. And some of the antibiotics that are here are doxycycline, tetracycline. You can see it's mostly of the cyclines, and also oral contraceptives for female acne patients are used as well. Benzoyl peroxide is remember, a lot of the peroxide can be cytotoxic, which is one reason why sometimes hydrogen peroxide is not a good idea to put on a pressure ulcer or an open wound, because it's cytotoxic. That means it kills cells. And unless specifically indicated for that reason, we would probably want to use debridement or so on and so forth. Benzoyl peroxide, as you can imagine, causes death of that specific anaerobic bacteria by slowly releasing oxygen, and because it's anaerobic, that oxygen will end up killing them, and therefore, again, remember, peroxide in any form is going to be cytotoxic, and this is what we want in this case, is that to slightly burn that layer of the skin off. And it has a keratolytic action. Remember that keratin, the layer of the skin, we want to have that lytic, that breakdown of that action, but because of that breakdown of that skin layer, it will have some reactions that are expected that should disappear once the treatment is stopped, and that's peeling of the skin, redness, localized redness to the area, sensation of warmth, and it can take at least a month to start to work. So we must inform our patients, especially the young ones who want to get rid of their acne quickly, to be patient. Clindamycin is another antibiotic used topically. The reactions, or adverse reactions, I should say, are limited to, again, same thing as I just mentioned, local skin area, burning, itching, dryness, or oilness. The dryness and oilness will be dependent on whether you or the patient's skin is naturally dry or oily, but it could change in the opposite direction, and ultimately peeling is very, very commonly seen in this population, especially with that drug. Isotretinoin, again, is used for severe recalcitrant cystic acne. It's more chronic. It's the acne that really just doesn't go away. It's an acne that is, in some cases, very symptomatic. It's very uncomfortable. for a lot of the patients. And what isotretinoin does is it inhibits the glands in the skin, the sebaceous glands, and creates, again, here's that word, anti-keratinizing effect. It's breaking that keratin level down. It's anti-skin hardening. It's loosening it up. And the good thing with this one, remember, it works systemically as well, is has anti-inflammatory effects. And so you can imagine if it's chronic, if it's highly inflamed, this probably would be the treatment. Normally, they won't start off with this treatment if they can avoid it because of its side effects. One of the meds that it was related to this, Accutane was withdrawn from the market from some pretty serious reactions. There are extremely stringent guidelines. I'm not familiar with the iPledge, but it's a program that patients have to be counseled upon. You have to be going through normal checkups, make sure you're not pregnant if you're going to be on this medication, and clearly monitor for signs of depression, suicidal ideations, and I believe even liver enzymes as well. Tretinoin or retinoic acid, vitamin A acid, retin A, again, used to treat acne. It helps also with skin changes that are related with sun damage. So if you have a sunburn that is not severe, this sometimes can help relieve a little bit of that. But again, what it's going to end up doing is stimulate the turnover of the epithelial cell. Remember, when we break the skin down with the topical drug, again, we should expect to see skin peeling. And again, it's important to inform our patients that that is a normal expected reaction. Many of the adverse effects of all of these local inflammatory, of these medications are local inflammatory as opposed to systemic, and they will be reversed when therapy is discontinued. If they aren't reversed and there's something else going on, patient would be advised to check up with a dermatologist or their primary doctor. Again, with a lot of them, again, reddening of the skin, but there are other effects that you might find, such as the swollen blisters, crusting skin, or alterations to the skin pigmentation or color, which could gray it out, it could make it yellower, could make it whiter, and again, that is an adverse reaction. If the blisters are very severe, if they're having an allergic reaction, the first thing we would always want to do is stop the medication and confirm with the doctor on furthering follow-up plan of action. Changing here to fungal infections, they're a lot more difficult to eradicate. Depending on if it's topical or oral, one is 4 weeks, one is 6 weeks at least, and many people with fungal infections have to come back for multiple treatments, sometimes even up to a year. The main problems we see with fungal infections are Candida, which is yeast infection, and you have tinea or ringworm infections as well, which are a fungal infection. And then again, remember that yeast is a normal part of our body, of our build, and of our buildup, of our tract from the mouth all the way down to the rectum. There's normal flora, normal Candida. And in patients, as I spoke to earlier today, with the word we use, opportunistic infection, is referring to patients who have depressed immune system, and HIV, or somebody who had an organ transplant and is on drugs that are trying to make sure the body does not fight against you don't want the body fighting the organ. You want the organ to be able to settle in. So these patients may sometimes end up having one of these thrush or fungal infection happen. That's why we call it opportunistic, because they take the chance and opportunity to grow more than they should. But again, they're normal in our body. Drugs that we use for funguses are, as you can see here, clotrimazole, and so there's even lozenges for the thrush and oral candidates. There in the hospital, you'll see a lot of the spit, swish and swallow, or swish and spit. So make sure you follow the order carefully. You don't want them swallowing it if the order is to spit it out. There's also suppository and creams for yeast infection. Other forms that are used we'll probably see, but they're not as common. And topical, and meconazole is another one. It's mostly used a lot for vaginal or suppository, or even a cream monostat. A lot of you might be familiar already with this. The thing with fungus infections is that they tend to like sugar quite a bit, and so eating high carb diets, eating lots of sugars, alcohol, all of these convert to sugar, and so sugar helps that yeast to grow. And the problem with Candida is, it's basically a sugar fermenting organism, as I just said, but it can produce these root-like structures. There's different shapes to it. One of them is like a rhizoid. And when these are in the blood, in the body, in the system, they can actually penetrate the mucosa or the intestinal lining of the wall. And these leave microscopic holes which allow toxins, undigested foods, particles, I should say, bacteria or yeast to enter into the bloodstream. In naturopathic world, yet to be fully recognized by allopathy or allopathic medicine, we call that dysbiosis, leaky gut syndrome, or SIBO, small intestinal bacterial overgrowth. And so diet is going to play a major role in it. The most common causes of antifungals really are overuse of antibiotics, right? Because they kill the friendly bacteria and allow that opportunistic growth to happen. Toxic metals, chemicals, an immune condition, a deficiency, as I already mentioned, and sometimes even celiac disease and quite a few others. But so can hormonal imbalance, which is absolutely necessary for friendly flora in the gut to be able to stay there. Antacids, as well, steroid hormones. Stress is a huge thing. Improper diet, as I said, diet high in carbohydrate and sugar, chronic constipation, the inability to get rid of the bowel movements, or chronic diarrhea, which gets rid of a lot of the good bacteria as well. There's quite a few things that lead to these fungal infections. And I think we'll see talk about onychomycosis shortly, which is that fungal infection that you see on the toenails in a lot of times. Acyclovir or denavir, which is another type of antiviral medication, are used for HS1 and 2 and the HPV infection, the human papillomavirus. They will not cure these conditions. It's just important to know that they reduce the time of which the patient suffers the symptoms and the pain, and it actually helps healing time, slows it down, but again, it won't cure it. Systemic drugs are better for controlling a lot of the viral skin. So you'll see sometimes topical medications can be used, but other times they just have to go in systemically. For anesthetics, we use them again for pain or itching, like insect bites, poison ivy. I'll upload a document with a couple of insect bites later for you guys to have, talking about different spiders and what we can do about it. Also, we use a lot of topical anesthetics to numb the skin right before a painful injection. Ointments, creams, sprays, jellies, liquids. Patches are used a lot of times, like lidocaine, to help with chronic pain from post-surgical situations or conditions. Antihistamine is what we use mainly for itching, and that's why we call it a topical antipruritic. Mostly we use corticosteroids, which are great because they have an anti-inflammatory effect. They also have an antipruritic, which helps with the itching. They do have a vasoconstrictor action, and if in high doses, if it does become through transdermal systemic, it can put the patient at risk for higher sugars and high infection. So you have to watch out with that and monitor those as well. But if a patient is really suffering, a lot of times you'll see patients that come into the hospital they might be on dialysis, and the dialysis nurse will call you up and say, hey, can you bring the antihistamine in, because the patient is just, and what you'll see a lot of times with patients that are waiting for dialysis especially is that since the kidneys can't filter a lot of the toxins that are building up in the blood, and until they get their dialysis, which might not be till later that evening or the next day, you need to help them with some antihistamines, because they'll just, as those toxins build up and that potassium builds up too, patient's skin will start to get quite itchy. So we need to treat that. And if it gets to a point where it's pretty severe or serious, just notify the doctor and say, hey, is there any way we could expedite this dialysis, which can be difficult in hospital settings because the scheduling. Some floors only have 1 or 2 available rooms to do dialysis in. Other topical dermatologic drugs that are used for psoriasis, right, are these following ones here. And that document that I said that I'd upload later has a little bit more in detail regarding psoriasis and a couple of medications that I'll expect you to know. So make sure you look at that Word document that I'm going to upload as well. Drugs that we use to treat pediculosis and scabies, Urax, benzyl alcohol, spinosad, natroba, these are all, and Quell as well, are pretty common for a lot of these parasites. Unless your patient is in the hospital, maybe homeless, sometimes they may not have some of these conditions. Some of the patients with really low immune system, if their CD4 count is low, they have AIDS, they may have quite a bit of these conditions that may require treating, but for the most part, this is a lot more commonly seen with primary care doctors or outpatient dermatology specialists. There is some hair growth products like minoxidil, Rogaine. Some people claim it really works great. Others have tried it and not that great. And for systemic hair growth, finasteride, Propecia, and it is category X, so we do have to keep that in mind. So pay attention to that. Women should not be handling these drugs. If you're a nurse and you want to get pregnant or are pregnant, make sure you have gloves on. Don't crush it. You don't want to make this airborne for sure. Sunscreens, it goes by SPF, which is the sun protection factor. And the higher the potency, the better the protection. Again, the higher the potency, the less vitamin D3 absorption will occur. So make sure you talk about vitamin D3. Remember, we're living in days of coronavirus, and if people's immune system is low, viruses can a higher likelihood of infecting you. Again, we're not saying here that vitamin D3 can reverse, treat, or cure something like coronavirus, but we do know without a shadow of a doubt that vitamin D3 is absolutely essential for the body to build an immune defense response reaction, and therefore it's absolutely necessary to at least be above a 30 if you've ever had your primary doctor do yours. Ideally, you'd like to be closer to a 40 or a 50, but you'd have to sit in the sun quite a bit or take quite a bit of supplements to get to that rate, because I think the government still is recommending 400 IUs on a daily basis, whereas a lot of people are taking anywhere between 2,000 and 5,000. We have to be careful with vitamin D because A, D, and Ks are all fat soluble. So if you take like 2,000 a day, every other day, or if you only want to take it once a week, you could take maybe 5 to 10,000. You'll still be getting a good amount. But I would highly advise of doing too much more because we don't know. We really don't know what the effects are. But what we do know is that what we're being told that 400 IUs is not enough. Not enough. A lot of people go to their doctors and they're close to 30. Some people are down by 8, 12, 14. And we know that myocardial infarction, stroke, and a lot of other conditions happen frequently when patients have low vitamin D. And it's good to know with sunscreen, back to where we were on the slide, that only the ones that have an SPF 15 or greater will reduce the risk of skin cancer or early skin aging. And again, on the face, it's really, really important, especially those that have family or personal history of skin cancer, to make sure you're protecting yourself. Protect your whole body with sunscreen, but give yourself a chance to get some vitamin D3 as well. Consider that sun just like taking a pill or a medication, because that's what it is. The skin does produce vitamin D. It only produces it when the sun hits it. If you have higher level SPF, you just probably won't be absorbing much, producing much vitamin D3, I should be saying. Anti-neoplastics, fluorouracil treat basal cell carcinoma and actinic keratosis. And this one is a little bit more common. You'll see this frequently in the hospital. Just remember, Effudex is for the basal cell carcinoma. There are immunomodulators that treat certain types of dermatitis, especially the atopic dermatitis. And the Aldera treats actinic keratosis as well as the basal cell carcinoma and some of the verrugas or the anogenital warts as well. Back to those anogenital warts, please pay attention as well to that Word document that I'm going to upload and look at the warts, because there's quite a few important points with that there. For wound care, again, vitamin C. Vitamin C is tremendous. And I'm telling you right now that in your career, you'll start to see, hopefully, maybe 10, 20 years, but for sepsis, patients who are severely septic, intubated in the ICU, there's significant data that's starting to show that vitamin C intravenous is very potent, very potent. The problem with vitamin C is we don't produce it. We need to consume it. And this, again, this is another thing that in times like today with coronavirus, D3A, zinc, and vitamin C are essential. Again, they won't cure, they won't reverse, they won't treat, but we do know that they help the body, the soil, the body that this pathogen is trying to infect, fight against it and keep it from actually being able to implant itself within us. As we saw, well, as a few of you saw, those of you who are in the clinicals with me on Friday, we looked at the medical surgical book, and in the perioperative chapter 17, it was talking about zinc for a lot of incisions, surgical incisions. There's some zinc gels, creams that can be used that help regenerate tissue and help with healing. They're fabulous. Zinc lozenges are very good as well at helping coat the throat. And remember, the throat is where the coronavirus tends to happen a lot. It's where it implants itself. And so you will see quite a few zinc ointments within the hospital. Sometimes they're used together with protective barriers as well. Moving on to the next, a Dakin solution. Here we're still looking at, that's significantly common in the hospital, and Santal is as well. Vinegar, not so much with wound care. The best person to talk to when you're in the hospital, expose yourself as much as you can to the wound care nurse, because they'll guide you, they'll show you what's best to do. Remember, with wound cares, you always want to know what type of wound it is and what type of management for the wound. There has to be an order, hopefully. Especially if it's a large pressure ulcer, we got to make sure that somebody has staged it, that it's charted, and hopefully we'll be doing 2 nurses skin checked within the first 24 hours. Otherwise, hospitals will end up taking the blame for any pressure ulcer, even if it was caused outside of the hospital. But Dakin solution is used frequently to clean a lot of the wounds as well. Skin preparation, a lot of times for, let's say, surgery, Hibiclens, chlorhexidine, 2%. There's different types of wipes that are used. You have to understand that anything that is used on inorganic material should not be used on the body or on babies or on your hands. That's basically for your computer, for the desktop, for wiping things around the hospital. Make sure you can find out if your computers are safe for some of those inorganic wipes. But for example, if a patient is going in your hospital to a procedure, let's say they're going to get an angiogram, they're going to go through, let's say, the groin, or they're going to do some type of surgery, then we would use the chlorhexidine wipes, and we have to maybe shave, not necessarily, we don't use razors anymore, we use the electric ones. And we would then have to clean the night before, and then the morning of the surgery, they would again wipe the groin, wipe the chest, wipe the leg, wipe the area again, and then they would do the same thing again in the preoperative setting. And again, we're just trying to make sure we prepare the patient properly to prevent an infection. Infection as well. With iodine, we have to ask our patients, there's Providine, there's Betadine, if they're allergic. Before we use that, because that's not common, but I have seen it 2 times in my career. So asking can save a patient. So be safe. There are quite a few herbal products. Aloe vera is used for wound healing. The problem with aloe vera, like consuming magnesium, is that it can have diarrhea or slightly abdominal pain, or even dermatitis. With magnesium, for example, I forgot to mention earlier. Remember, a lot of not only do we give transdermally or through the skin drugs, but we can give vitamins and supplements through the skin. And magnesium is a case in point where if the patient really should be on magnesium or at home, I personally take it transdermally because it will make me have, if not the diarrhea, really loose stools. If you spray it on yourself, and again, it should be 100% magnesium oil, nothing else in the ingredients, just 100% magnesium oil, you can sidestep the GI tract and you'll prevent from having the loose stools, and it can boost your magnesium status without giving you some of these adverse effects. Aloe does the same thing. Be careful with aloe and a lot of the antidysrhythmics, diuretics, and digoxin, because it can affect the effectivity of it. Or in digoxin's case, I believe it can actually increase the potency of it. So you want to make sure that you ask patients a lot of times before they go into surgeries if they're taking any herbs, because there's side effects. And we know that ginger, garlic, ginkgo, fish oil, for example, are all good examples of things that might lead to bleeding or more bleeding, or aspirin, right? We want them to stop this at least a day before they go into a surgery. Nursing implications, we always need to assess for allergies and any contraindications, right? Just like we're going to ask what arm can we take the blood pressure on in case they had breast cancer, or if they are a dialysis patient, we may not want to be using the arm that they get dialysis on. Remember, just like before we give an antibiotic to a patient, we always want to, if they're having a fever and we don't know yet what infection they have, and we're getting ready to give them a broad spectrum antibiotic, we always want to do the blood cultures before we start the antibiotic, which absolutely makes sense. Well, same thing here with dermatological, topical, transdermal, anti-infective drugs. Don't give it until the culture or the sensitivity is tested. If it's been ordered or until you complete it. For example, if you have a wound and you're going to send a sample out, collect it from the wound before you apply any antibiotic to the wound. That might be infected. Nursing implications, again, regarding isotretinoin, and again, here, finally, they do say it here, okay, we do want to monitor liver function before and during therapy, and that they follow the guidelines. And we want to make sure we do a pregnancy testing before, and they need to get prescription renewed on a regular basis to make sure that they are not just getting it and not following up with what we want to monitor. And the other thing, again, with this one, remember, is depression and suicidal ideation. We always want to assess thoroughly before we apply any medication. If you ever see at any point a question that says, hey, just you have in order to apply this medication, if you're not sure, you may always want to think, okay, well, is this something that I know for a fact that I need? And you only know if you need something if you've always assessed. And just remember, we always assess before we intervene, okay? And keep in mind that systemic absorption to pay your patients, your client, are really higher in the very young and the very old patients. And especially as people age, the skin thins naturally, and therefore the same dose that somebody who is in their 40s will be higher in somebody who has thinner skin, or in the typical lady who has asthma, COPD, and they're on steroids continuously. Their skin breaks easily. So just pay attention to the fact that, and not only that, but how can they excrete the drugs as well? Remember, first day of Pharm, one of the key things is, are the kidneys able to excrete the drug? Are the liver functioning properly to be able to help break it down and eliminate it as well? So not only will they be at risk for a higher dose, but they may be at risk for it staying in the system longer if they're unable to get rid of it properly and as they should. So always follow the guidelines, always follow the doctor's instruction, read carefully, read your MAR, cleanse the area thoroughly, remove any debris, residual medication. I tend to rotate like some of the sites that we use for a lot of the local anesthetics patches. Unless they have pain in that one spot and we're treating that pain in that area. But generally speaking, you want to clean it up, make sure it's dry. Sometimes a lot of the patches won't stick if they're dry. Make sure you always chart, look for a patch on the patient and actually look for it. Don't just listen to the patient. If they're elderly, if they're forgetful, if they just want to have more of that lidocaine dose to be higher numbed or more numbed, they may say, oh, I don't have another patch. And so now you're putting a patch onto them when they already have a patch. And technically speaking, that's an overdose. So always remove a patch before you put another one on. And with nitroglycerin, for example, it really helps to clean the area up as well, because if the area is oversaturated, the skin may get to a point where it may not absorb as much or as well as it should. So just rotate that to the other side of the chest until next time as well. And make sure likewise with the vasodilators such as nitroglycerin that we're removing those as well, because vasodilating can drop the blood pressure, heart rate, and if they already have a patch on and you don't remove it, now you give them a second patch, you're basically putting them at risk for dropping their blood pressure, and we could cause a problem that we don't want to cause. Wear gloves always when applying topical drugs. Please wear gloves. We should be wearing gloves when we put a slap a vital sign machine on. I still see students go into the room and take a vital sign without their gloves on. I mean, this should be common practice. If you're going to get anywhere close to the patient, and if you're brave enough to say, oh, it won't affect me, I have a strong immune system, okay, yeah, still, but think about the patient. You're in other rooms with patients that may have bugs, and almost guaranteed they do, and you may be carrying it into the room, so always wash your hands and wear the gloves. And apply dressings based on the order. Some dressings are wet to dry, occlusive. So when in doubt, call the wound nurse to come in, have them take a look at it, give you some suggestions, and or contact the doctor and see what type of care they want. Normally speaking, again, a pretty big pressure ulcer will have a wound nurse on the case, and so there should be a note somewhere in the system. So make sure you look for those notes as well. We're getting close to the end here. A key thing: if you did it but you don't document it, you didn't do it. So always document on the patch or in the computer system or both the site of where you applied it. If you're in the MAR and you're getting ready to patch a nitroglycerin ointment on a patient, or you're putting a patch on the patient, make sure you say left lower lumbar region, right upper chest, so that when I go in on the night shift, if I have one to give, or the next day the nurse has one to give, they can go to the previous one, highlight it, and it'll say where it was. That nurse's job is a lot easier. You go right to it, peel it off, now you can put a new one on. And always chart when you're documenting in the MAR, found patch in the right lower lumbar region and removed. Placing this patch in the left lower lumbar region, right lower, upper back, so that the next nurse can be informed as well. And it's always a good practice to chart what you did. Monitor any swelling, temperature, what the site is like. Odor, color, pain, other sensations, what type of treatment was given, ice, heat, elevation, and how the patient responded to the treatment. Remember, we want to protect certain areas from sunlight, especially if you're taking some of those tetracyclines. It'll make the skin worse. Do not double up. If there's a dose that was missed, just give the next dose when it is due next. Don't double up or give more than what you should be giving, and that everything is disposed of in the proper contaminated protected area. Usually in a lot of hospitals, those red biohazard bags that go into the red biohazard bin. Provide patient and family teaching so that they know how to take care of it. This is a huge thing for patient discharge when patients get ready to go home, how to care for it. Make sure they have a thermometer, make sure they know the signs and symptoms of infection, calor, rubor, dolor, right? If their pus starts to come out, white pus, yellow, green, obviously those are signs of infection. Generally speaking, we suggest them to not treat infection too early on, because remember, infection is the natural process of the body wanting to heat up. Usually a lot of times in hospitals, there'll be a standing order to say give this antipyretic if fever is above 102 or above 101.5, something of that nature, and then you can treat when it's above that. Otherwise, don't. Monitor always for responses. Document what the responses were. Swelling went down, redness went down, heat went down, or swelling has increased, redness has increased, pulses are disappearing, and then what actions we're going to take to follow up with the doctor to figure out what we can do at that point, and always monitor for adverse effects. And ladies and gentlemen, we are done with that. That said, please go online. I will upload this presentation will be uploaded to YouTube, is what I'm going to try. Hopefully that's where you guys are watching it. And make sure you go into Canvas on RN28 and the Pharm to look for that Word document under dermatology. So you guys have a good rest of the evening, day, or night, depending on when you're watching this. And thank you for your patience and your flexibility. Have a great day or evening.